Hello everyone. In this video, we are going to discuss a topic which is not only important for surgery, but it's important for every medico irrespective of their specialization, and that is acute pancreatitis. To start with, we will discuss anatomy of pancreas. Pancreas has four parts to be specific. First part is the head, which is further divided into head proper and uncinate process. Second part is the neck, third part is body, and fourth part is tail of pancreas. There is a main pancreatic duct to secrete all the exocrine secretions of pancreas, which is also known as duct of Wirsung, and there is another accessory pancreatic duct which is known as duct of Santorini. Here is the common bile duct, which combines from gallbladder, that is cystic duct, and common hepatic duct together give common bile duct, and they both open together into second part of duodenum in ampulla of Vater. If we consider some embryological aspects, this pancreas is derived from mainly two structures. First is dorsal pancreatic bud and the other is ventral pancreatic bud. The dorsal pancreatic bud forms superior part of head, neck, body and tail of pancreas, and the ventral pancreatic bud forms inferior part of head and uncinate process. Blood supply of pancreas is from superior and inferior pancreaticoduodenal arteries. Superior pancreaticoduodenal artery is a branch of gastroduodenal artery, and inferior pancreaticoduodenal artery is a branch of inferior mesenteric artery. Now we come to functional aspects of pancreas. Pancreas has exocrine as well as endocrine function. Here in this video we will discuss exocrine pancreatic functions. Pancreas secrete digestive enzymes by acinar cells. These acinar cells secrete proteases, amylases, lipases, DNases and procollagenases. These all enzymes are secreted in inactive form, which are later activated, and their secretion is augmented by enterokinase, which is secreted from Brunner's gland of duodenum, cholecystokinin, which is secreted from I cells of duodenum, and secretin, which is secreted by S cells of duodenum. So these three enzymes are secreted from duodenum, and through vascular interconnecting channels they go into pancreas and activate acinar cells. Their functions are different, which I will discuss subsequently. First of all, and when the protein and fatty contents reach duodenum, duodenum releases enterokinase. This enterokinase goes into pancreatic circulation and cause acinar cells to secrete these enzymes in their inactive forms. Amongst proteases, the enzymes are trypsinogen, which is activated to trypsin, chymotrypsinogen, which is activated to chymotrypsin, procarboxypeptidase, which is activated into carboxypeptidase, and proelastase, which is activated into elastase. These enzymes are converted into their active forms by enterokinase. Then what cholecystokinin do? Cholecystokinin cause these acinar cells to increase their secretion. Cholecystokinin promote the secretion of acinar cells, and this enzyme secretin, it makes duodenum alkaline, because all these enzymes are active and are maximum functional in alkaline medium. Now the question arises that how the duodenum medium is made alkaline. So this alkalinity of medium is done by pancreatic ductal epithelium. The pancreatic ductal epithelium has specialized cells which have two kind of channels. First is SLC9 and other is SLC26. These two enzymes take in carbonic acid, which is formed from atmospheric carbon dioxide and water inside the intestine, and then they convert into H ion and bicarbonate ions. These H ions are exchanged with sodium ion by the channel SLC9, and the SLC26 channel is the main channel which causes bicarbonate secretion into the duodenum lumen, which makes duodenum alkaline. And these bicarbonate ions are secreted in exchange of chloride ions. In cystic fibrosis, in which there is a chloride deficiency in body secretions, these channels are deficient. In this way, secretin, which is secreted from I cells of duodenum, cause pancreatic ductal epithelium to release bicarbonate ions into duodenum, and thus they ensure proper functioning of these enzymes of pancreas in alkaline medium, because when food reaches duodenum it is mainly acidic due to mixed gastric acid with the food, and when it reaches the duodenum it needs alkalinity in the form of bicarbonate ions so that those enzymes can function properly. Now we come to acute pancreatitis. Acute pancreatitis is acute inflammation of pancreas, as the name suggests. First we will discuss its etiology. To remember its etiology, there is a famous mnemonic which is known as I get smashed. I for idiopathic, G for gallstones, which is also the most common cause of acute pancreatitis. The second most common cause is ethanol or alcohol. Then T stands for trauma, S for steroids, M for mumps and other infectious diseases. M can also stand for certain malignancies, especially those which cause pancreatic duct obstruction. A for certain autoimmune diseases, S for snake or scorpion bite, H for hypertriglyceridemia and hypercalcemia. E stands for an investigation which is known as endoscopic retrograde cholangiopancreatography. I will discuss this investigation in detail later. And D for drugs. To remember the drugs which cause acute pancreatitis, and these drugs to be remembered are very important for pre-PG exams because they are asked in one form or another. So there is another mnemonic to remember this. Glad organ pancreas is traumatized and destroyed very much easily. Glad for glucocorticoids, organ for OCPs, pancreas for pentamidin. The S of is stands for sulfonamides. Traumatized for tetracycline, and for azathioprine and antiretrovirals. Destroyed for diuretics, very for vancomycin, much for metronidazole and easily for erythromycin. Now the question which arises is, what is actually acute pancreatitis and how it is caused due to these agents? The answer is, pancreas is basically an enzymatic organ. Pancreas, when disturbed, causes release of these enzymes in blood, which causes automatic apoptosis not only of pancreas but also of surrounding organs if these enzymes are released in blood. So what happens is, when any inciting events come, like those agents which I discussed, they cause co-localization. There is a process called co-localization within pancreatic cells. What is this co-localization? This occurs within 15 minutes of inciting events. What happens is, zymogen granules, pancreas contains some zymogen granules which contains trypsinogen enzyme, means trypsin enzyme in active form. And there are lysosomes also. These lysosomes contain an active enzyme which is cathepsin B. What happens is, when any inciting event happens and it disturbs the pancreas, then these zymogen granules and lysosomes combine together. It means that this proteinase enzyme, it means that the enzyme which cause protein to break down, this trypsinogen enzymes get activated into its active form, which is trypsin, and cathepsin B itself gets activated, and these two enzymes cause apoptosis and necrosis of pancreatic cells. Now, what happens when this apoptosis occurs? Not only the pancreatic cells are destroyed, but also certain inflammatory mediators are released into blood, which are interleukin 1, TNF alpha, IL-6, IL-7 and so on. What these all inflammatory mediators do? Through blood circulation, not only they cause necrosis of pancreas, but they also go into surrounding organs and through distant organs also and cause acute inflammation. So you get all features of acute inflammation, and that's why this acute pancreatitis is not only harmful for pancreas, but it releases these enzymes, these destructive enzymes throughout the body, throughout the blood circulation, and wherever these enzymes go, they cause intense inflammatory response and hence the symptoms. The important symptoms are: first is pain. Patient will have a characteristic epigastric pain radiating to back, and patient will have a posture of stooping forward, which is sometimes also known as namaz position. Then patient will have all features of hypotension. Why hypotension? Because intense inflammation in all organs causes massive vasodilation and exudation of fluids. So patient will have all features of hypotension such as dizziness, syncope, and also patient will have breathing difficulty. Breathing difficulty would be there because pancreatic fluid will also cause acute inflammation in lung, causing acute respiratory distress syndrome and acute lung injury. And subsequently, these pancreatic enzymes may also reach kidney and therefore cause acute kidney injury. So what we can see here is there is a multi-organ dysfunction syndrome. What is multi-organ dysfunction syndrome? Involvement of two or more than two systems of body. So here we can see CVS, RS, and also GIT. In GIT we can get gastrointestinal hemorrhage and excretory system. All these systems can get involved, so there would be a multi-organ dysfunction syndrome. If not controlled, will eventually lead to death of patient. Actually, these symptoms are of bimodal distribution. First, the death or the morbidity, to be specific, because not every time it leads to death. There can be a mortality or morbidity. So what happens within 2 weeks? Within 2 weeks, the death or morbidity would be mainly due to this intense inflammatory response which occurs. These all, that hypotension and acute lung injury, everything acute. Okay, so all the involvement of all the body parts would be acute. So this intense inflammation would be the cause of morbidity. After 2 weeks, the main problem is sepsis. What happens is, not only this inflammation causes the organs to react in this way, also due to intense inflammatory response, the defense system of body is affected. It means that body becomes more prone to infections because all those defensive first line and second line agents of body that are various interleukins and whether neutrophils, macrophages, they all are consumed at a very high rate. So there are none left to protect body from infections, and therefore after 2 weeks the patient may land in sepsis, and this may be a cause of death or morbidity. Now I will discuss pathophysiology of some specific causes, that how these causes cause pancreatitis. To start with the most common cause, gallstones. Gallstones mainly cause obstruction to flow of pancreatic enzymes. So what happens is these pancreatic enzymes get accumulated and thus their subsequent activation and destruction and apoptosis of pancreatic cells. Second, an important one is alcohol. How does alcohol causes pancreatitis? Alcohol causes release of an product which is known as NFK beta. This NFK beta, it also causes apoptosis and necrosis by activation of cathepsin B and interleukins. Also, alcohol causes spasm of sphincter of Oddi. It causes direct injury to pancreas, and also it causes obstruction of the pancreatic ducts. So, in this way alcohol causes pancreatitis. Then another one important one is ERCP. What is ERCP? Endoscopic retrograde cholangiopancreaticography. By name it suggests that through endoscopy we go up to duodenum, up to ampulla of Vater, and there we can perform any intervention which can be diagnostic as well as therapeutic in the hepatobiliary tree. So what happens is this ERCP, as it goes close to ampulla of Vater, it causes disturbance and destruction of pancreas. Either it may be injury to pancreatic parenchyma, or it may be injury to sphincter of Oddi, which can cause again apoptosis, necrosis and inflammation. Another one is hypertriglyceridemia. Now what happens is that these are a group of disorders, okay, which are classified from type 1 to type 5. You must have studied them in your biochemistry classes. So what happens is hypertriglyceridemia type 1, type 2 and type 5. These specifically, the patients of these disorders are specifically at risk for acute pancreatitis, especially when their triglyceride levels are more than 1000 mg per deciliter, and if the levels are more than 2000, then it's diagnostic. Also, hypercalcemia. Now what happens is, there is a paradox. Hypercalcemia causes pancreatitis, but pancreatitis itself causes hypoglycemia, hypocalcemia. I will talk about it later. Hypercalcemia, how it causes pancreatitis? It causes activation of trypsin. That is, it facilitates conversion of trypsinogen to trypsin, and this trypsin then further causes destruction, as I have already told. Also, this calcium gets precipitated in pancreatic duct, and that's why cause obstruction and then enzyme activation and destruction. Among symptoms, I want to add how hypocalcemia is caused due to pancreatitis. Now what happens is, when this all destructive process is going on, what happens is there is precipitation of free fat inside the bloodstream. And what happens is this fat then combines with calcium to form calcium salts, or we can say soaps, because they are combined with fatty acids. So this saponification occurs, which cause excessive consumption of calcium, and that's why decreasing calcium levels, and that's why it causes hypocalcemia. Now we will come to diagnosis. What happens is, during this intense inflammatory response, certain enzymes and certain biochemical or hematological markers are altered in our body, and they suggest pancreatitis. The most important of them is serum amylase. Actually, it's not that important in the way that serum amylase is raised in our body in many acute conditions. So it's not that specific, but it is very sensitive. So serum amylase can give you a hint towards acute pancreatitis, and if any of the other risk factors are present and serum amylase is high, so you can also then predict that okay, the cause is most probably pancreatitis. So serum amylase is one important marker, but more specific one is serum lipase. And why it is so? Because amylase and lipase both rises, but lipase rises in much less conditions as compared to amylase. So the lipase is, if serum lipase is increased, then it is more specific towards diagnosis of pancreatitis than serum amylase. Serum amylase just gives us a direction to evaluate for pancreatitis, but it is not diagnostic at all. And same with serum lipase, though it is more specific than amylase, but it doesn't mean that if lipase is raised, then it's sure shot acute pancreatitis. Okay, so let me tell you about some scoring systems of diagnosis. There are many scoring systems, out of which the most important from exam point of view is Ranson scoring. It has 11 criteria. Okay, we have to look for 5 criteria at the time of admission, and after 48 hours of admission we have to look for another 6 criteria. And what we will do If patient has come initially, we will first means I will discuss this in management. We will first resuscitate the patient, and if the patient becomes more stable, then we will send patient for certain investigations. And if in ultrasonography we found gallstones, so for gallstone pancreatitis there are some different criteria, and for non-gallstone pancreatitis there are some different criteria. So I will discuss these criteria one by one. At the time of admission, we have to see 5 criteria. I have a mnemonic for remembering these criteria, which is AG law. A for age, G for serum glucose, L for LDH, A for AST, and W for WBC. These criteria are: for non-gallstone pancreatitis, age more than 55 years. For gallstone, more than 70. Glucose more than 200 for non-gallstone. For gallstone, it's 220. LDH more than 350 for non-gallstone. For gallstone, it's 400. AST more than 250 for non-gallstone, and for gallstone also it's 250. WBCs more than 16,000 for non-gallstone, and for gallstone it's more than 18,000. After 48 hours of admission, I have a mnemonic for that. Bob has cute smile. B for base deficit. Base deficit more than 4 for non-gallstone pancreatitis, more than 5 for gallstone pancreatitis. PaO2, that is oxygen saturation, less than 60 for non-gallstone pancreatitis, and for gallstone it's not specified. B for blood urea nitrogen, it's more than 5 for non-gallstone pancreatitis and more than 2 for gallstone. Has for hematocrit fall, more than 10% for non-gallstone, and it's same for gallstone pancreatitis also. Serum calcium less than 8 mg per deciliter for non-gallstone and also less than 8 for gallstone. Then SMILE stands for sequestration of fluid from the body. Non-gallstone it's more than 6 liter, and for gallstone pancreatitis actually it's not specified, but in some books it is given that it's more than 4 liter. So this is the Ranson score. At the time of admission, we have to look for these 5 criteria, and after 48 hours of admission, we have to look for these 6 criteria. If the score is more than 3, these all criteria are given 1 point. So if the score is more than 3, it is diagnostic of acute pancreatitis. Another score which is important is Apache score, which is acute physiologic and chronic health evaluation score. This score has 12 points. I will not go in details of it because it's not that important, but this score has 12 points, and again a score of more than 3 is diagnostic of acute pancreatitis. If you order CT of patient, means after stabilization of patient, if the patient is stable and if we can send that patient for CT, then there is another very good diagnostic modality, and this score actually also gives the percentage of mortality and morbidity, and that's why this score is the best of all. This is known as CT severity index, which has combination of Balthazar score and percentage of necrosis of pancreas. How this Balthazar score is calculated? If on doing CT we get normal pancreas, then score 0, mild inflammation of pancreas, then score 1, peripancreatic fat degeneration, then 2, 1 phlegmon or fluid collection foci present, then score 3, and if 2 or more than 2 phlegmon or foci of fluid collection are present, then we give score of 4. Percentage necrosis: 2 for less than 30%, 4 for 30 to 60%, and 6 for more than 60%. This percentage necrosis is of pancreatic parenchyma. It means that how much parenchyma of pancreas has been necrosed. So what happens is we add these two scores, and if the score comes 1 to 3, then percentage mortality is 3% and morbidity is 8%. If the score is 4 to 6, mortality is 6% and morbidity is 35%. And if 7 to 10, the mortality is 17% and morbidity is 92%. So a CT severity index of 10 is very dangerous, and we should resuscitate this patient to the best means possible. There is another criteria. This criteria is specifically very much diagnostic of acute pancreatitis. If the CT of patient is not possible, then we can go for Ranson score, Apache score, or and there is another diagnostic modality which is C-reactive protein. This C-reactive protein is mainly diagnostic after 48 hours of starting of symptoms, and a peak of more than 150 is diagnostic of acute pancreatitis. As I have discussed, CCT is the best modality of diagnosis. If we come to radiologic investigation, then CCT is best. We can also go for ultrasonography, which will only tell about collections. If any collections are present inside the body, it is one of the complications, and I will discuss it separately. And also it will tell about gallstones. So it will tell about the etiology. Ultrasound will help in diagnosis by etiology. Another thing we can do is we can go for ERCP if none of the etiological agents are being diagnosed by other diagnostic modalities. Because gallstone is the most common cause of pancreatitis. So if we find gallstone in USD and we find no other reason for inciting pancreatitis, then we can go for an ERCP. Though it is itself a cause of pancreatitis, still if we feel that there is a stone in this hepatobiliary tree and it is causing obstruction of pancreatic secretions and thus all the complications, then we can go for endoscopic retrograde cholangiopancreatography and can not only diagnose those stones but can also remove those stones subsequently, and thus we can aid in treatment of pancreatitis. Talking about one of the most basic investigative modality, X-ray, it is not that diagnostic if pancreatitis is concerned, but as far as our competitive exams are concerned, many times X-ray findings of acute pancreatitis are asked. So here I will tell some of the findings of X-ray of acute pancreatitis. First is ground glass appearance. Then what happens is, due to intense inflammation, the intestine goes in ileus. So there will be multiple air fluid levels. As we know that air fluid level presence indicates intestinal obstruction, and due to this intense inflammation the peristalsis would be hampered. So there would be a kind of paralytic ileus for the intestine, and therefore we can see multiple air fluid levels. Then we can see a colon cutoff sign. This is caused, here we will see a part of colon, just a part of colon is visualized, and after splenic flexure no colonic gas will be seen. This is due to a spasm of splenic flexure. And we will get widening of C loop of duodenum. Why this widening occurs? This widening occurs because there would be inflammation and enlargement of pancreatic head. So pancreatic head is just adjacent to duodenum, C loop of duodenum. So when there is an inflammation in pancreatic head, what happens is there will be enlargement of C loop of duodenum, and that's why we see widening of C loop of duodenum on X-ray. But this investigative modality is obsolete now. It's just for the matter of competitive exams that I am discussing them. Now we will come to management, which is the most important thing. First, you have to resuscitate the patient with the standard protocol of ABC, that is airway, breathing and circulation. First you have to ensure that if the patient's saturation is falling, then you have to ensure that his airway is patent or not, because sometimes due to excessive secretions in this systemic inflammation, there may be choking of the airway due to excessive saliva. So rapid suctioning of the airway, as well as keeping giving a Godel's airway inside the naso-respiratory pathway, it may help. Also, if the saturation is very less and the patient is of altered consciousness due to hypotension, then you can also intubate the patient. Then we have to come for breathing. So breathing, we have to see that whether patient is able to breathe or not, whether the lung expansion is proper or not. Sometimes the patient is there is an acute respiratory distress syndrome or lung injury. Then in this case also intubation will help. Then we have to look for circulation. As I have already discussed that patient is in shock, so resuscitation with IV crystalloids is very necessary. You have to put 2 IV bore needles wide bore needles in patient. You can also do a central line insertion to monitor central venous pressure, and then you have to resuscitate the patient according to his or her BP. That you have to bring BP more than 90/60 by intense resuscitation by crystalloids. Then after the patient becomes stable, means the saturation is okay, the BP is normal, then you have to see what is the another thing which is bothering the patient. It's not only the hypotension. Actually, the most important symptom is pain. So what to elevate pain, actually we can give morphine or other opioids, but some books have postulated that it causes spasm of sphincter of Oddi, therefore it aggravates pancreatitis. But it's not proven, it's just a theory. And opioid analgesics are best in relieving pain. So in some centers still opioid analgesics like morphine or tramadol are given. In some centers it is not given. Then we give NSAIDs. Means it depends from doctor to doctor according to his or her choice. Then the other thing is nutrition. After pain, after we have resuscitated the patient vitals are okay, the pain is relieved, then we will go how to provide nutrition. See, what happens is in acute pancreatitis, there is acute inflammation and therefore the intestine is in ileus. So we cannot allow oral feeding to patients. So oral feeding is banned, okay. Not banned is not a right word, means it's withdrawn. Patient is not allowed to take anything per oral. Instead, patient has an option of parenteral nutrition or enteral nutrition. Now, what is this enteral and parenteral nutrition? Parenteral nutrition is nutrition given through IV lines, and enteral nutrition is you put a Ryle's tube which directly goes into stomach, and then you allow feed through this Ryle's tube. Means you are giving food directly to stomach, the liquid food, and there is a pulse water, or you can give milk, or you can give fruit juices, and they will directly be given through Ryle's tube. Actually, initially parenteral nutrition through there are prepared formulas like total parenteral nutrition TPN, which are known as, which contain all nutrients, means all the proteins, carbohydrates and fats in adequate amounts which are required for body, and it is calculated as per nutritional requirement. So it is a very good preparation formula which is given through IV route, but its disadvantage is that it causes intestine to become inactive, right? Means you are not stimulating intestine, you are directly giving nutrients through IV route. So what happens is there would be intestinal atrophy, and intestinal atrophy would be there, and decreased blood flow would be there to intestine, and that's why the microbes will grow, so sepsis will increase. It happens in long term. Actually, it does not happen immediately, but in long run, these are the disadvantages of total parenteral nutrition. So sometimes the patient will end up in sepsis, and sometimes the bowel may become gangrenous. So these are so long term TPN should never be given. We can start with parenteral nutrition, but should shift the patient as soon as possible to enteral nutrition. That is, we should give feeding by Ryle's tube. This will remove these drawbacks. It will cause intestinal proliferation with increased blood flow and will prevent sepsis. In long term, enteral feeding is better than parenteral nutrition, and if the patient has improved overall, then after a few days we can start oral nutrition. Now I will discuss complications of acute pancreatitis. Pancreatitis as an acute condition, if managed properly, will not land up into complication most of the times, but still there may be some complications such as peripancreatic fluid collection. This fluid, if in a small amount, will be reabsorbed itself by peritoneum, but if in large amount and if it is causing pain and intestinal obstruction due to pressure, then it should be drained. Then the most important and most fatal complication is necrosis. More than 80% of times, if the patient died of pancreatitis, in autopsy we find pancreatic necrosis as a cause. What is pancreatic necrosis? It is presence of non-viable pancreatic tissue. And as I have discussed already in pathophysiology, you know that due to apoptosis and necrosis, there is presence of non-viable pancreatic tissue, and this is a very fatal thing to happen. Why this happens is, what happens is, due to intense inflammation, there would be mucosal reperfusion mismatch injury. Means there would be lack of proper pancreatic perfusion, proper pancreatic blood supply, which will then cause cells to degenerate. And during this degeneration, what will happen? Inflammatory mediators will be released in blood. And these inflammatory mediators will cause subsequent degeneration of not only pancreas but also of surrounding tissue, and that's why necrosis happens. So what happens is, necrosis when pancreatic tissue is deranged, not only it will affect the exocrine and endocrine function, but also it will make patient a focus of sepsis. This sepsis is mainly caused by gram-negative organisms, and this sepsis is the main culprit in causing mortality of patients with pancreatic necrosis. So, what is the treatment? Actually, if there is any sterile necrosis is present, it means what you have to do here is you have to look for an FNAC. You have to look for fine needle aspiration cytology, which can be CT or USD guided, and you have to take a part of pancreatic tissue and you have to see whether it's infested with gram-negative organisms or not. If gram-negative organisms are present, you will label it as septic necrosis. And if necrosis is sterile, it means if it does not contain gram-negative organisms, then you can conservatively manage this patient. Then you can try of conservative management. If the patient improves, it's okay. If the patient doesn't improve, and if means there is lack of improvement plus or plus minus if there is infected necrosis, then you have to go for surgical interventions here. Means surgery in acute pancreatitis is seldom needed. Most of the times, as I have already discussed, we will conservatively manage patient. But if there is infected necrosis, then you have to go for surgical intervention. And also, when the patient is not improving on conservative management, then you have to open and explore the patient. And what are the modalities of exploring? We can go for open laparotomy and can debride the necrotic tissue. It means we can do the removal of necrotic tissue. And if not possible, then what we can do is we can just do packing of that necrotic tissue, and we can open it or leave it open, or we can do a closed continuous irrigation. It means we just put drains inside, and from outside we can flush the peritoneum. We can flush the peritoneum with crystalloids, and then all the infection will go out through the another drain. Means from one drain we will give fluid inside the peritoneal cavity, and from the another drain it will come out. So all the infection, all the sepsis will come out. So it will also help in relieving patients, because there is a famous saying in surgery that don't mess with pancreas, because pancreatic tissue is full of enzymes, and that's why it is very dangerous to just play with it or disturb it. So we don't have to go for extensive surgeries over pancreas. We should try, if only if expertise is available, then only we should do the debridement of necrotic tissue. Otherwise we can just do closed irrigation drainage, or it can be also a percutaneous drainage. Means we can drain the infected fluid from outside. Other complications are pseudocyst formation, pancreatic ascites, and pleuropancreatic fistula. Now, what is a pseudocyst?